So anyways, glad to be part of this. Of course, glad to be part of Wolf's and and not out on my own during a time like this. I think I also would say that Gavin, I really appreciate everything that he's done because it's been a pretty Herculean task. And overall, the direction of the practice, I think, is a good one. And I'm happy that we're going to emerge one day on the other side. I was going to actually also Dr. Sadat. I know he's been working hard. I know that when he finished his draft for the governor at 1 o'clock, he immediately jumped to Facebook because I've read a lot of his opinions. So I know he's been really cranking out those. I'm going to start with a slideshow, and I'm going to start that now. So this is kind of a wide-ranging slideshow, and I'm gonna, maybe I can figure out how to unmute people here. Can everybody see this? Can you see this, guys? Tom, can you see it?
Yeah, it's good, Joe.
Yes.
Yes. Okay, great, thank you. So, so I'm gonna get started. It's a wide-ranging talk, and I'm going to explain where I'm going with this, but it's about the context. First, I think it's helpful. It's been a crazy time to just kind of take a breath and kind of recap exactly how we got to where we are. The challenges that we face, the specific solutions that we have and how we derive those solutions, and then opportunities for improvement, maybe even in the long haul. So, without any further ado, review of our experience in the United States and Georgia specifically with COVID-19, projections for what may come to pass, a review of current recommendations and guidelines for practicing in healthcare in Georgia, a summary of the measures of Wolf's and I Institute to meet the challenges of COVID-19, a look ahead, and I'm also going to share a stock photo of some guy getting ready to sprint on a beach somewhere. There's that part. Check that box. So, cited in this talk, a lot of sources. Whitehouse.gov, Opening Up America, again, Executive Orders Brian Kemp, which I read in painstaking, nauseating fashion. The American Enterprise Institute with Dr. Scott Gottlieb, who's widely recognized to be really the expert on this issue, the Harvard Global Health Institute, some popular magazine sources like Time Magazine, which has an interesting story to tell. CMS, the COVID tracking project, you should go to covidtracking.com. You can see up-to-the-day stats anywhere you want, any state or in aggregate. OSHA, I looked at the American Dental Association. I looked at the American Optometric Association Practice Reactivation Preparedness Guide. CDC, not just cleaning and disinfection, but other things. American Academy of Ophthalmology has been a very good source and would be worth looking at because they've had a ton of publications. But most importantly, pooled experience and guidance from fellow professionals, other practices, competing ophthalmology groups, referring optometry groups, non-referring optometrists, dermatologists, lawyers, as we're all kind of in this together. And I think utilizing those sources to come up with best practices is going to be important going forward. And certainly in that spirit, anything that we have, any documents that we've generated in our response and sort of our operations, we'd be happy to share. So I'm going to start, I think for the tone, reading a letter from Dr. Park, who's the current president of the American Academy of Ophthalmology. And so Dr. Park says, we are not returning to normal. The lessons learned from COVID-19 may mean that the normal of January 2020 may never approximate the normal of the future. We will have the SARS-CoV-2 virus with us for years. We will always have the memory of what it means to shelter in place for weeks on end, to furlough staff, and to defer patient care. What we must do now is develop the processes to provide patient care in a new normal. This will not be an issue of waiting for someone to signal all clear and turning on the lights. We'll have to make decisions about protocols for use of PPE, antibody testing of staff, expectations as to social distancing. Make no mistakes, SARS-CoV-2 is still with us. The risk of virus transmission and serious illness or death is still with us. We must be thoughtful and careful for our patients, our staff, colleagues, for ourselves, and for our families. Okay, so I think that, to me, encapsulates the tone in my mindset. I don't think science is going to come and save us tomorrow. I think we're going to be dealing with this, and we're going to be dealing with this long term. And so why don't we just approach it with the idea that some of these changes we're making are going to be permanent? And that's my mindset. So the COVID era begins in the United States. This is from the American College of Surgeons on March 15th in Seattle. All hell was breaking loose. With nursing home patients and surgeons were facing an explosion. They called on their colleagues in Milan to say, what's going on? How did you manage this? And at that point, 90% of the ICU beds in Milan were filled with COVID patients. And all patients over 80 were automatically labeled DNR. Across the board, if you're 80, we are not going to give you life-saving care if you need it. If you need resuscitation. If you're over 70 with significant comorbidity, it is too risky for us to resuscitate you. It's not worth it. Your prognosis is too poor. And that's called crisis level care. Since then, you can see this is data that I compiled into graphs from the COVID tracking project. It's quite accessible. Positive tests in the US starting on March 4th to 425, just this past weekend. And if you look at what happens in Georgia, I labeled when that Seattle phone call happened. And since then, we've had exponential growth as well, up to say 23,000 or so confirmed positive cases. This is the data which I think is actually the most helpful. On the left, you have the percentage of positive tests for all tests administered in the state of Georgia from March 18th to April 25th. And I labeled their various political events like the shelter-in-place order on the 2nd of, actually, it should be on the 20th. No, it's the 2nd. I'm so sorry. It's on the 2nd where it's labeled currently. It's correct. And you see that there's exponential growth and then it starts to level off. You have a little peak there. Maybe it's a backlog of testing. And then you see from the 25th until the 4 days preceding, we actually had a sustained, essentially daily decrease in the number of positive tests. We peaked at 26%. We were at 18% a couple days ago. Now that's an important number because the World Health Organization says that you really should target having only 10% positive tests. If you have 18%, you're not testing enough. Because it's like they used to say in surgery, if you're not taking out enough normal appendices, you're not doing enough appendectomies because appendicitis kills young people, okay? So the next on the right, it's actually the most encouraging slide that I have, shows the daily marginal increase in testing. This means a positive deviation on the graph means you tested more than the week before, and you can see that the testing is ramping up exponentially. In the last 7 days, we had almost 52,000 tests, 72 tests per 100,000 per day. Those are important numbers for various models we'll talk about. So this is the timeline of what's happened in Georgia with executive orders. On 3/14, state of emergency. That's about when Seattle was getting hammered at the onset. 3/16, school closures. 3/23, shelter in place for vulnerable populations. 4/2, shelter in place for everyone. 4/20, reopen Georgia. I should put 4/23 where he says, I didn't really mean that. Here's a bunch of rules you can't follow. So statewide shelter in place. 4/2, all residents, except if conducting in essential services or engage in minimum basic operations or part of critical infrastructure. And this is that 6-foot spacing. Now I do list here all the minimum basic operations for one reason. Even though we are not bound as medical practices by these minimum basic operations, we are specifically actually exempt from them in the executive order on the 20th of April. Nonetheless, it's our responsibility to implement as much as we can, and indeed the requirements of our various societies. But if you're the landlord that owns this site where you're practicing, you are bound by this. So you have to be very careful, because as landlords, you still have significant liability based on the minimum basic operations standard. This is my favorite executive order, the face mask executive order. This is what I call it, you can wear a mask to SunTrust order. It says that there was a code which said you can't wear a mask to conceal your identity, but now you can if your goal is to prevent spread of COVID. 4/20, 2020, yay, everything's open. And this, we talked about this, how you actually are at risk and bound by the minimum basic operations if you're a landlord, and that we should practice in accordance with CDC, blah, blah, blah. 4/23/2020 this is the equivalent of one hand giveth, the other hand taketh away. Because I think what happened is when Brian Kemp got pressure from the right and the left and didn't get the presidential approbation, he walked it back by making rules and regulations that are essentially legal nightmares to follow. So, for example, your salon is supposed to increase physical space between staff and clients. That's how can you do that? So, it's an interesting read, but just to show you an example of some of the problems, you're not supposed to gather more than 10 people if they're not spaced by 6 feet, but your restaurants can have 10 patients per 500 square feet. So I just kind of figured out how that would look if I assume that patients have mass and take up volume. It seems pretty tough to get to 10 people. And then if your restaurant's not a perfect square, then you have even more problems. So anyways, that's just me having fun with regulations. But the whole thing is a tangled mess. And to me, it's actually reassuring, because it means less people are going to be out doing stuff they shouldn't be doing. Okay, so where are we headed? I think probably the best voice on this is Scott Gottlieb at the American Enterprise Institute National Coronavirus Response. This was released the end of March, and it was a roadmap to reopening it. And believe it or not, the gating criteria from whitehouse.gov are largely based on this. I subtitle it 20 Pages of Sheer Depression. We're currently, we were phase 1, which is slow the spread, social distancing, blah, blah, blah. And the goal is to increase testing capacity, at least here nationally, to 750,000 tests per week. So we'll talk about that. And at that point, once you have enough testing in the population, you can start to then zero in specifically on cases and do contact tracing to dampen down the infection completely. So if you assume a population in Georgia of 10.2 million, which is 2015, it's probably not accurate, we should be doing, based on that data, 23,000 tests per week. Maybe it's 30,000. We did 50,000 last week, so I feel real good about that. We're halfway to the standard that the Harvard people think we need to stop this pandemic, but we're certainly in the ballpark for both of those models. So that's probably the most reassuring piece of data I can give you about the trajectory of this pandemic. Okay, so slow the spread. Then we have to implement contact tracing, which is really, I don't know where we are with that as a country, but it takes literally hundreds of thousands of people to track millions of contacts. As you know, you try to call a patient to have them keep an appointment. It takes an army to get 10 patients to keep their appointment. Imagine contact tracing for millions of people. So I'm wondering where we can find a few 100,000 people who just lost their job and pay them to do. Oh, right, they're everywhere. So this should be quite easy for us with the right leadership and direction to be able to pay these people to help us with the next step. Triggers for moving to phase 2 in the American Enterprise Institute, sustained reduction of cases for 14 days. That we did not meet in Georgia before moving to phase 2. All people with symptoms can be tested. We may be close to that. All confirmed cases and contacts are actively monitored. I'm not sure we're there. I do know that hospitals are not currently resorting to crisis levels of care in our region. So CMS says if you have passed the gating criteria, they recommend at that point you can move to phase 1, and they give you a link to whitehouse.gov for the gating criteria. And I found this when I hit it's a 404 error, page not found. So right away I was feeling good about our government, but then I actually went to whitehouse.gov and I used a very powerful light And using that very powerful light, I could find the gating criteria. Downward trajectory of flu-like illnesses, number one, for 14 days. I don't know if we've met that for 14 days, but I know it's certainly been below baseline for a week and a half or two. We can talk about that. It's problematic because people are staying the heck away from doctors. So if you got a flu-like illness, you're not going to go to the doctor. Are you kidding me? Downward trajectory of documented cases within 14 days, or downward trajectory of positive tests as a percent of total tests within 14 days. We probably were 8 or 9 days when Kemp made that executive order. So it's a little premature, but nonetheless heading in that direction, and we're not treating patients with crisis care. We talked about that. This is our map of downward cases as a percent of total. I showed you that. If trends continue, we would be meeting that today. I expect we are. Hospitals, yeah. So the trends are good, but we haven't had enough data to definitively say that this is a responsible decision. I don't think the governor's move was crazy, but it's definitely a gamble without a full data set. Well, with the caveat that the part about opening tattoo parlors and fitness centers is crazy. I'm gonna just draw a line there. So what happens if we're wrong? Then we could think about Hokkaido, the cost of being wrong. This was in Time magazine. So this was the Japanese island, a couple million people. And this is a lesson, maybe a lesson Dr. Kemp, Brian Kemp, he may rediscover asymptomatic transmission, because what happened is Hokkaido was initially a model for how to contain and eliminate coronavirus. And they got this down after 3 weeks of serious lockdown. They got it down to like 1 new case a day. And agriculture and tourism were really creamed as a consequence, and businesses were getting antsy, and they lifted the restrictions. And so when they lifted the restrictions, it was like the Wizard of Oz, or like ding dong, the witches, da, 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 and they all went out like 3-day weekend. Schools reopened, and literally 26 days later, they were back on lockdown, and now they're still in lockdown, and all the economic pain of their first lockdown was for naught. And so we might be recapitulating that mistake in Georgia. My only quibble with, my real quibble with the executive orders and news conferences is the tone needs to be a little more severe, because we can't all just rush back out. Another word of caution, and this I take from your own society practice reactivation preparedness guide. It starts by saying this pandemic, by all accounts, is a temporary event. I will tell you there are many accounts that disagree with that. And I think that's the wrong spirit with which to approach the modifications you're going to need to your life, your practice, your livelihood, everything. I think this is totally unfounded and a dangerous precedent. We don't know if recovered patients develop lasting immunity. Coronavirus mutates. We may have a treatment, which we don't, but it may not last. We have no vaccine. I know other viruses we don't have vaccines that we've been looking for literally decades. We have no good treatment for active disease. We do not have adequate contact tracing. We might have a new strain every year like the flu, okay? So I would say to assume this is gonna peter out is, I would sure love that to be the case, but I don't have confidence in that. I also don't have confidence that science is going to shoot a bow and arrow into the middle of it and just take it apart. I'm not sure. So expect this to change your practice for years, and might as well make these changes permanent, because 2 years of changes, it's pretty much permanent. So now that I'm done, and I was only partially on the soapbox, I'm going to talk about some of the multi-agency and society recommendations that we're basing our action plan at Wolfson Eye on. They're widely overlapping. They're very similar. American Academy of Ophthalmology has been prolific. I find their publications to be the most useful. And these guidelines, combined with discussions with regional practices, lawyers, optometrists, ophthalmologists, dermatologists, plastic surgeons, surgical centers, hospitals, has informed our own guidelines. Your society recommends developing standard operating procedures that are very well documented. And I think that's really important, because there's going to be some liability here. Develop processes for sterilization. This is all from your action plan, from your society. Try to improve your HVAC system, reduce volume, use telehealth, virtual care whenever possible. keep inventory, ensure appropriate PPE, limit guests, keep people out who don't need to be out. And then there's a lot of sort of squishy stuff, like figure out if the door is going to be locked to limit entrance, or on the other hand, keep it wide open so that there's fresh air. I mean, this is going to be a work in progress. And so I think your standard operating procedure should have a 1.0 and a 2.0 and a 3.0 because they're going to change every day. Messaging to patients, how are we going to keep
Hey, Joe.
Yeah.
Hey, Joe, why don't you explain why the HVAC is important?
Well, you can take viral filters, viral particles out. So in the surgical center, like our ASC exchanges the air in the room 15 to 20 times per hour, complete exchange. And if you wait 15 minutes, that means that 99.9% of virus is gone if you exchange the air. And then the filter itself, it's just the viral particle itself is about 1 micron. If you have a high quality filter, you can actually filter the virus out. That's why they say if you're on an airplane and you're in the back seat and someone's got COVID in the front seat, you're very low risk to get it because of the quality of the HVAC system in airplanes. Is that anything else, Jonathan? Did I miss what you wanted?
That's good, Joe.
Okay, I thought you might have fallen off the treadmill again. I'm sorry. I'm going to pay for that. Okay, so CMS recommendations. Things that I've plucked from CMS. Now, I haven't listed everything here from CMS or OSHA or anyone because all of these are pooled and a lot of these recommendations are in multiple sources. They say consider establishing non-COVID care zones that screen patients. For example, screening patients outside of your waiting room. Every effort should be made to conserve PPE. The funny thing is JCO used to tell us that hot joint whatever, blah, 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 for accreditation of hospitals used to tell us, change your PPE every time you turn around. Now they're like, never change your PPE. So how the times have changed. Patients should wear a cloth face mask. Use telehealth and virtual care. You can see how to take PPE on and off properly on the CDC website. AAO recommendations, be wary of conjunctival secretions, which can harbor virus. They also say that SARS-CoV-2 is susceptible to the same treatments we normally do to disinfect our office. Social distancing, facial coverings, disinfection, COVID screening prior to waiting rooms, keep the waiting room socially distant, keep vulnerable patients away, slit lamp barriers, no talking during the slit lamp examination, and wear proper PPE, N95 gown, gloves, face shields for treating COVID positive patients, or send them to someone who can. AAO has a guide to physical modification of the office space. It is really common sense. We've thought of these things before we even saw this publication. Eliminate high-risk surfaces. No more coffee machine, no more water machine, no more magazines, no tables. Space out the chairs. Protective screens in front of the testing equipment, front desk, slit lamps, floor markers, proper ventilation, signage from the CDC, hand sanitizer deployment. I have to be careful. You can't deploy hand sanitizers that people can put in their pocket because you will have them for about a half a clinic. So you need to get something that's wall mounted. Try to eliminate shared workstations. This is all sort of common sense stuff. CDC, as I said, their guidance has been incorporated into really everything that I'm talking about. So I put here procedural modification 7.0 because it seems like we've been working on these around the clock for a couple of weeks now. So I'm just going to review sort of what our approach is and how we're going to move forward really starting Monday. Our guiding principles, we're going to offer the highest level of care. We're going to adopt aggressive measures that are certainly consistent with community standards or beyond. We're going to reassure our patients, but also our staff with the safety and efficacy of efficiency of our environment. Improve communication with durable teaching materials like video and printed materials so we can still connect with our patients even without them being in front of us in the clinic. So before they come to the office, the patients are given a lot of different methods for receiving registration paperwork, ideally electronic, and ideally they return it electronically. The least exchange between staff and patients, the best, just like it's better to pay with a credit card than it is to pay cash. Our calls to the patients will do the history taking, chief complaints, medication updates, other charts before their visit. They'll be administered a COVID screening questionnaire. if their appointment is within a week of the scheduling. We have patient instructions we're going to communicate and expectations for the visit. Our call center has a script to read. The patient instruction says you're going to wear a face mask. If you don't have one, we're going to give you one. You should arrive alone, maybe one essential guest at most. Arrive outside to the designated location where your COVID questionnaire will be administered. Proceed to a temperature screening. If your temperature is less than 99.5, you get a sticker that says your name, and you head to the waiting room. We escort you there. Why need a sticker with your name on it? Because everyone's wearing a mask. And so Mrs. Johnson, our 69-year-old lady with hard of hearing, you call her 7 times in the waiting room and she's still not there. And then 45 minutes later says, nobody called me. Now she's got a mask on. So Miss Johnson needs a name tag. Okay, the instruction sheet, blah, blah, blah. How about this? Shut off Face ID. If you're wearing a mask, you got to keep your mask on. Wear your name tag at all times. Don't bring food or liquid because you can't drink food. Well, you can't drink food anyways, but you can't eat food or drink liquid without taking your mask off. Don't bring extraneous stuff in the office. Don't move the chairs. They're spaced the way they are for a reason. No standing. Sit unless you're at the check-in counter and try to limit cash transactions. Unless there's an urgent need, know that you will not be seen if you have a positive screening questionnaire, you have a temperature greater than 99.5, or you fail to comply with our safety measures. And we'll give you resources that you need if you fail our screening measures. Passive physical measures. We got to imagine this is a long haul, and eventually, maybe, we're going to get a little soft. The most passive measures, the best. Remove extraneous furniture, cluster the chairs, permanent barriers, wide deployment of sterillium hand rub dispensers, signage, dispersion of testing equipment into regions with better ventilation with possible. And because at Wolfson and I, we have 5 different offices, we're going to have site-specific customization of these guidelines. Our active, those are passive. Our active safety measures: don't share pens, wipe down clipboards. We have someone who's going to be identified as the hygiene monitor in our clinic. Going to walk around with a spray bottle, the 2 tablespoons of bleach in a quart, and clean all the surfaces. Help make sure everyone's socially distant. Help with the temperature screening. Help with the flow of the clinic to keep people away from each other, into the exam room, and then out of the office. The examination will be fairly silent at the slit lamp, questioning and discussion at a safer distance. Exam rooms are going to remain open for ventilation. Each technician ideally will be in their own room, so there's less cross-technician contamination or potentially risk. Limitation of congregation of staff. Surgical scheduling is a meet and greet affair now. They're not going to sit down and talk about surgical quotes and blah, blah, blah. That's going to be done over the phone. And some of us of the practice have been working on video counseling, high-quality video production, so that we can offload some of the surgical discussion with the idea that, look, if that's not enough, and if you feel like you have questions, let's do a telemedicine follow-up. And for me in oculoplastics, I've done some telemedicine, probably I've signed up 30 surgeries in the past month and a half. I've had about 60 telemedicine visits. I find patients to enjoy them. Actually, they don't have to go drive to the office. They don't have to sit in the waiting room. And, you know, occasionally I do need to bring them in for a test or to see them for a specific consideration, but in general, it's been very well received. We talked about the hygiene monitor, blah, 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 blah. Staff hygiene. Staff wear scrubs to work, take them off, put them in a bag, and wear your jeans home. Staffs do not touch a patient without gloves. They wear medical masks at all time, eye protection. Shut off your face ID, wash your hands every time you touch or remove your PPE. Keep your mask on until break time and don't touch it. Wipe down your devices. Forms and documents, we have a lot of them, and again, happy to share them with you. Messaging to patients, how are we keeping you safe? Call center script, how we're keeping our patients safe. This just is meant to reassure patients. COVID screening questionnaire, instructions that are going to be sent to the patient at the time of their appointment. Call center script, what they say when there's a phone call. What are the opportunities with sort of our new, fresh approach to clinical ophthalmology? Well, I think in some ways the patient experience is going to be improved, because what do patients really care about a lot? They care about wait time. Well, there ain't going to be no wait time. Offloading history and paying closer attention to the flow of clinic is going to reduce wait time significantly. For oculoplastics, patients love telemedicine if it's 0 wait time, 0 travel time. and we just shoot the breeze. Durable instruction materials the patient can access anytime. We are working on that to make that better for patients. And while we have reduced volume, we're incorporating improved electronic medical records and practice management software, leading to improved communication with patients and referring doctors. A renewed sense of caring and an improvement in our environment, focused on safety and well-being of staff and patients. And we're also going to be very receptive to taking our 7.0 manual and making it 7.1 and 7.2 by getting feedback, 360-degree feedback from technicians, from front desk, from patients, from other staff. We might just appreciate our role in the greater healthcare community more as we work with our affiliates, referral sources, direct competitors, non-eye care practice. We continue to develop and hone best practices. And maybe, and I think maybe I'm speaking personally, we don't have all the answers as we frantically run around pushing patient after patient to our offices. And maybe this has been a useful time for reflection. So I hope my mic was on for that whole thing. I unmuted everybody.
Sorry.
And I'm going to regret that. I'm going to mute everybody again. Does anyone have any thoughts or questions? You can chat, and I will pick up that thread.
So, Joe,
chat questions?
Yeah. Thoughts on wearing gloves. My thought is yes, wear gloves. That's my thought.
Excellent answer.
You know, I do a lot of tear drain, probing, chalazion procedure, stuff like that. I know there's COVID in the conjunctival secretions. I don't know when the last time you've done a slit lamp exam and not touched the eyelid margin, either with a Q-tip or finger. So you should definitely wear gloves.
Steve Wilson wants to know, what is your definition of essential eye care?
Essential eye care, I think you would have to say, largely falls on trauma, serious infection, significant glaucoma problems, corneal ulcers, retinal, macular degeneration treatment, malignancy, orbital tumors, dacryocystitis, certain neonatal issues, congenital ptosis where there's threat of amblyopia. And I'd be happy to hear whatever anyone else likes to add to that.
Well, presbyopia, of course.
Presbyopia, even, you know, 1 or 2 diopters of astigmatism.
Chris Hoskins says, my staff prefers pleated surgical style masks because they are significantly inferior. Are they significantly inferior to the N95 masks we have? Absolutely.
They're far inferior, but they're far better than nothing. But here's the better point. What mask is your patient wearing? Okay, because to be honest with you, the masks are to prevent the asymptomatic spreaders. So you put a mask on, it sends a message, and I'm definitely wearing a mask because it may give me a couple more % protection, but my patient's going to have a mask. You better believe. In fact, I'm going to do surgery with my patients in a mask. It's not going to look good.
Eric Colgrove, who has left town, but we still love, says, will you email your slides to everyone as well as the forms you're using? I'm going to answer that question. Anyone who wants whatever they want, send me an email and I'll get you what I can get you. And the answer is, that's pretty much a yes.
Yeah, no problem.
Do you allow patients to come in without masks? Do you provide if they do not comply with instructions given?
Yes.
Prior to
no one's going to be, there will be no occupant of any of our suites without a mask, whether they are the doctor, the technician, the front desk, or the patient, or the patient's guest. And I should also point out that the patient's guest is going to be screened and non-contact temperature assessed as well, not just the patient.
As well as the doctors and staff. I mean,
yeah, every day, doctors and staff, there's a logbook for that.
There's somebody named Kelly who's asking the question, what mask will you put on your patient if they don't have one? I don't know who this Kelly person is.
Well, so, you know, it'd be one of our normal medical masks. And
Completed ones.
yeah, and I would go so far as there are some with adhesive across the bridge of the nose and cheek. When I do surgery, upper lid surgery, my patients are going to be wearing those.
Are you utilizing plastic face screens along with masks?
The answer to that is we have face shields, which are not disposable, which are reusable. We have ordered about 100 of them, 150 of them there for every employee gets one of those. I'm not sure I'm going to be able to use it, but I'm going to try. But I will be wearing my safety glasses at all time, and I will have my AirPods in at all times. So I don't put stuff next to my face. So AirPods, safety glasses, and mask, and scrubs.
And we'll be having the shields at the slit lamp as well.
Slit lamp barriers, yeah.
Yeah.
Well, we seem to have run out of questions. Jonathan, do you have anything else you'd like to say to our guests?
No, I just encourage everyone to stay safe and take these precautions. The one thing that I think the biggest take home for me would be, this is not going away. I really believe we're going to be seeing ebbs and flows for the next 2 years or 18 months, whatever it is. This is a long-term change that we're making. And the way we counsel patients, the amount of time you have face-to-face, whether you're not talking to them when you're so close face-to-face is just really important. And a good reminder of that is, the first doctor in Wuhan province in China that raised the alarm, who got into trouble and then eventually was vindicated. He was an ophthalmologist and he contracted the virus and died. So this is real. And he was young. He wasn't a 80-year-old with several comorbidities. I believe he was in his 40s and healthy. And so that is rare. Most of the time, people are older, but I think when you're that close, you can get a bigger viral load. And if you get a big viral load, then younger people are much more susceptible. So I just encourage everyone to take this seriously, figure out what your protocols are going to be, and then make sure you adhere to them.
A question just came in for Dr. Wolfson. How many miles did you log on the treadmill?
Not enough.
Okay. Another question is, the face shields are not working in our office. They fog up, can't communicate on phone. There's no question mark, but what advice would you offer, Dr. Walrath?
Try a different face shield. Where you could wear safety glasses.
Safety glasses.
Safety glasses is better than nothing. I got to believe that.
Yeah, Dr. Kazem, I don't think he has AirPods. He's asking AirPods question mark. I think.
I sent that back to him with the private answer. It's connected to my iPhone so that when I have the urgent call from the referring doctor, I can take it without putting my phone up to my face. It'll just be like,
Very good.
Always standing by to take your call.
Okay, so here's the deal. You guys will get 0 credit hours for the hour and a half or hour and 15 minutes that you spent with us. We will do an update of this course in the next few weeks, and it will hopefully be with CE credit, almost for sure be with CE credit. Also, we have recorded this event, and we'll let people know where they can go to review it. And obviously, some of the people that were invited didn't make it. But we did have a nice crew show up. We had about 75 of you, so thanks for joining us. And just let us know how we can help you. And thanks for supporting us. And good luck out there, and be safe.
Yeah, be safe, everybody.
Good night, everybody.
Good night. Goodbye.
Hey, Joe, good job. You put a lot of work into this, and it's helped the clinic, and I think it's going to help the community. So well done.
Yeah, I think we're moving in the right direction.
Good job, everybody.
Good night, everybody.